speak to you guys today about this topic. As we said, in the interest of time, I'll get right to the presentation. So to start, this is the INUS session. So INUS is the International Urology Society, for those of you that aren't familiar with it. It was established in Zurich in 2015. And really the mission is to educate and bring together clinicians with an interest in urogenic bladder and neurourology. There's an annual meeting each year. This year will be in Turkey, and I'll tell you a bit more about that later, but it's a great honor for me to be here to represent INUS and present this lecture today. So the objectives, two objectives today. One, I want to review some of the common complications associated with neurogenic bladder, and then two, I wanted to discuss a rational approach for the assessment and follow-up of patients with neurogenic bladder. So the first question, what is neurogenic bladder? So it's not clearly defined, and that's one of the challenges with this. It's generally accepted to mean lower urinary tract dysfunction in a patient with a defined or a presumed neurologic disease. So what do we usually think about for neurogenic bladder? Usually we think about the big three: spinal cord injury, multiple sclerosis, and spina bifida. However, included in neurogenic bladder are numerous other conditions as well that don't come up as much when we're discussing guidelines or doing studies on neurogenic bladder. And that's multiple other conditions like cervical myelopathy, cerebral palsy, stroke, multisystem atrophy, Parkinson's disease. And then there's things in the lower urinary tract as well, like diabetes, lumbar disc disease that affect the lower motor neurons and technically still are also covered as a neurogenic bladder etiology. So what are some of the urologic causes? Well, the first thing we're all taught as urologists is to watch out for the kidneys. And renal dysfunction is a major source of potential morbidity for people with neurogenic bladder. Traditionally, this was a very high risk issue for people with spinal cord injury. The risk of renal dysfunction led to death in a large majority of patients in historical cohorts. However, in more recent cohorts of patients, the risk is much lower. Still elevated, still about 2.5 times non-spinal cord injured patient populations, but much lower than historical rates. Spina bifida, generally it's mild renal dysfunction that we see in young adults. Only 2% have renal failure. Still a risk, but a very low risk. Multiple sclerosis patients, again, this is important to know, MS patients have a very low rate of renal dysfunction. When we look at studies after a median of 5 years of follow-up, there's some subtle upper tract changes in 5 to 10%, but no patients have renal dysfunction associated with this. But what about the other urologic consequences? So renal dysfunction is the first thing we think about, and we all pat ourselves on our back when we see a patient, they don't have renal failure, but there's numerous other things that we have to think about when managing these patients. Urinary tract infections, incontinence, renal stone disease, bladder stone disease, bladder cancer, and then some of the iatrogenic complications that come along with neurogenic bladder, like urethral erosions from chronic indwelling catheters. So let's start with renal dysfunction. So why do people with neurogenic bladder get renal dysfunction? Well, usually there's two things that are happening in the bladder on a basic level. One is the bladder wall composition's changing. It's beginning to have fibrosis and collagen depositions changing. And then there's also increased tone in the bladder from neurogenic tone. This leads to a couple of changes, which we usually see on urodynamics when we do it: poor compliance, neurogenic detrusor overactivity, and then elevated PVRs. This can then go one of two ways. The patient can have a low detrusor leak point pressure, which we often see in adults with spina bifida, for example, or patients can have a high detrusor leak point pressure, often what we see in people with spinal cord injury and DSD. The patients with the high detrusor leak point pressure are the ones that are going to have high risk of renal dysfunction. These are the patients that aren't just going to leak urine, they're going to actually store that urine in the bladder. That high pressure is going to get transmitted up to the kidneys. They're going to get decreased renal blood perfusion, vesicular reflex, hydronephrosis, and go on to renal dysfunction. It tends to be a problem predominantly with spinal cord injured and spina bifida patients, but is rare in other diseases. Often has no symptoms, and that's why really we worry about prophylactic investigation or surveillance investigations in these populations, because we want to try to identify some of these changes at this stage here, at the urodynamic stage, before we get to this stage here. Urinary tract infections, I won't say too much about this. We have an excellent lecture coming up later in the session on this already. Suffice to say, it's a very common occurrence in people with neurogenic bladder. A third have annual urinary tract infections. People with spinal cord injuries are 10 times more likely to have serious infections than the general population, and still 10% of the population dies from mortality from sepsis. Most of the time that's urosepsis. There's multiple etiologies why people with neurogenic bladder and specifically spinal cord injury have multiple infections. It's important to know some of them you have some control over, some of them you don't have much control over. The use of catheters, there's immunologic changes in the bladder that happen after a spinal cord injury, and then there's various patient and virulence factors that contribute to these infections. Diagnosis is a challenge. It's not as easy as doing a urine culture and saying, oh, you have infection, let's treat it. The important take-home message for me today for this is surveillance cultures generally aren't useful in this population. What you want to do is you want to try to treat people with symptoms. Over-treatment of infections has been a major issue, I think, worldwide, especially in North America. Antibiotic resistance and some of the harms of chronic antibiotic use have been well documented, and as urologists, I think we have to take a stand in trying to provide some rational treatment and rational use of antibiotics, especially in neurogenic bladder. So what about incontinence? So incontinence is common in the general population, and it's particularly common in people with neurogenic bladder. If we look at the three main populations here, you can see it ranges from about 30 to 60% depending on the patient population. It's a very common complaint. While this can be a quality of life issue for some people, it can also cause serious complications for others. People in wheelchairs, incontinence is going to contribute to skin breakdown. Sacral ulcers and pressure sores are still a major source of morbidity in this population. And the tricky thing with incontinence here is it's multifactorial. There are numerous different things that can be going on that can be leading to the incontinence, including detrusor overactivity, overflow incontinence from an elevated PVR, stress incontinence, poor bladder compliance, functional issues just with mobility and not being able to transfer or make it to a washroom in time. It doesn't take fancy investigations to tell a patient has incontinence. It takes a history and a physical exam to start the process. So when assessing patients with neurogenic bladder, I think one of the keys we really have to do is look for incontinence and try to quantify it and understand how it's affecting both quality of life and the medical care. So moving a little bit on to surveillance. So how can we follow these patients and try to maintain and maximize their health and prevent complications over time? If we look to what the current guidelines tell us, you can see there's a variety of different societies up there that have guidelines for neurogenic bladder, but they're all over the place. There's really no consensus. The only thing that has some degree of consensus is that of imaging. Most guidelines recommend imaging to some degree at various frequencies. Probably the consensus would be once a year for a renal ultrasound, maybe a bit more frequently early on in the disease process. Again, these are called neurogenic bladder guidelines, but really what they're talking about is guidelines for people with spinal cord injury, spina bifida, or maybe more advanced MS. These guidelines really don't address people with Parkinson's disease or stroke and bladder dysfunction. Things like urodynamics, cystoscopy, renal function testing, again, no real consensus on how these should be used in the management of neurogenic bladder patients. A nice systematic review done by Dr. Cameron in Michigan a few years ago showed that imaging is really the only area where we have evidence to suggest it's useful as a surveillance test. So what do I propose? Well, I would propose an evidence-informed strategy. There's really no direct evidence that allows us to say surveillance is useful and it should be done this way. No one's done randomized trials of observation versus routine surveillance for people with neurogenic bladder. We have to extrapolate from cohort series and retrospective case series and try to come up with the best answer for how to manage these patients. Evidence-informed strategy means that you stratify patients based on the etiology of their neurogenic bladder. We know some neurogenic bladder etiologies are higher risk than others. You define risk factors during your initial evaluation of them, and then you use those risk factors to identify patients that require urologic surveillance or those that maybe don't require so much surveillance and can be managed by a primary care doctor. And this is the approach we took when we developed the Canadian neurogenic bladder guidelines, which were published earlier this year. So what can you do for surveillance? So for neurourology, really there's 3 tests you can do for surveillance. You can do renal imaging, which usually is a renal ultrasound. You can do urodynamic studies, and then you can assess renal function and get an assessment of the patient's GFR. So how can you use these across the different disease states? Well, first thing to know is that there's various different conditions out there that would make someone a little bit more high risk. And you can debate some of the finer points of these and what the cutoffs are, but I think we can all recognize when we see a patient with one of these high-risk features. When you see someone for the first time, I do think baseline investigations are important, especially with high-risk diseases. So urodynamics, you're looking to get a sense of their bladder function. Main things you're looking at there are things like compliance, DSD, neurogenic detrusor overactivity. It's important to identify those things and then try to treat them. You want to look at the renal anatomy and see if there's existing hydronephrosis, existing atrophy or scars. It's not uncommon. You'll find someone who has an atrophic kidney from chronic infections as a child with spina bifida, and then all of a sudden you've got a patient with a solitary kidney. That patient, in my books, becomes a high-risk patient where you really have to follow them carefully to try to maintain that one renal unit that they have left. Finally, there's issues with bladder management that might make patients more high risk. For whatever reason, patients aren't always able to manage their bladder in the ideal way. Some people use condom catheters still or reflex voiding in the setting of DSD. Some people use indwelling catheters, either urethral or suprapubic catheters. These patients are more high risk, not just for renal dysfunction, but for complications in general, like we talked about, incontinence, urinary tract infections. These patients deserve closer follow-up and closer optimization of their bladder and kidney function. So once you have an understanding of what the high-risk features are, you can start thinking about how to use them to risk stratify patients and select the highest risk patients for more intensive surveillance. So what our consensus was in the Canadian group was, how do you define a high-risk bladder? Well, one thing is the etiology of neurogenic bladder. So we've got the big three here again: spinal cord injury, spina bifida, wheelchair-bound MS, or more advanced MS. I think these are reasonable to assume they're higher risk patients based just on clinical experience and based on what's in the literature. All patients would get a baseline history physical exam and then the three assessments we talked about: ultrasound, urodynamics, and an assessment of renal function. After that, you have to sort of think, okay, is this patient a high-risk patient or a medium-risk patient? I would never call one of these patients low risk. So high-risk patient means they have some of those features that we talked about on the last screen. You want to try to optimize their bladder function and then repeat the investigations again. And the repeat investigations would be another ultrasound, another urodynamics, and another assessment of renal function. If you've done a good job and you've optimized their bladder, for example, you've treated their NDO, their hydronephrosis has resolved, everything looks good in year 2 when you see them back, or 6 months when you see them back, then maybe they go down to a medium risk patient. They're using their intermittent catheters, they're on anticholinergics, they're doing well. At that point, you might want to switch them to a less intensive surveillance strategy. So that means renal ultrasound, urodynamics, and renal function testing in one of two situations. I still think periodic testing is important, but it probably doesn't need to be every year at this point, or if their bladder changes on history and physical exam. So what about all the rest, right? There's all this low-risk neurogenic bladder population out there too that still fall under neurogenic bladder. Neurogenic bladder guidelines usually don't specifically address these populations. What should we actually be looking for and doing in these populations? So I would say these patients are patients that don't have a spinal cord injury, don't have spina bifida, and don't have more advanced MS. These patients you evaluate with a history, a physical exam, a PVR, and a urinalysis, and then from there consider whether or not they need more invasive testing or not. Ultrasound, urodynamics, and renal function should be used selectively in this population. You can do these in certain situations, like when you're planning more invasive therapy or when someone has an elevated PVR. In the absence of any concerning findings, you don't need to follow these patients yearly with investigations. You can follow them based on symptoms, or they can be followed by their family physician and referred back when there are issues. Obviously, there are always going to be complications. There are going to be patients that are high risk in this with cerebral palsy or with early MS that you do wish to follow. But in general terms, if you don't identify anything serious, these patients can probably be followed in a less invasive manner. In conclusion, I think the rational follow-up of a neurogenic bladder patient requires a few things. You have to be comfortable with a good neurological history and physical exam. You have to be able to address renal function, infections, and incontinence. You need to identify patients at higher risk and investigate these patients. and also consider surveillance in a rational form in these patients going forward. Thank you. And that was perfectly timed with 1 second to spare. Thank you.
Thanks.